everyone. I hope you're able to refresh during the break and perhaps meet some of your fellow attendees, and that you're ready to dive straight back into the exciting learning ahead. Our next panel is all around innovations in infection prevention and control. What are the new technologies that we've been able to introduce to support staff and patients' safeties? Have there been innovative working practices that have changed how we manage infection control for the better? There are so many different ways of approaching innovations in the IPC space, because make no mistake, against the backdrop of significant challenge over the past 18 months, we've made dramatic strides. It's crucial that the momentum continues and that we learn from the pandemic and develop measures for infection prevention beyond COVID. Well, joining me to discuss these innovations are Professor Anthony Fisher, Consultant Clinical Scientist in Medical Physics and Clinical Engineering at Royal Liverpool University Hospital, and Dr. Julie Samuel, Head of Department and Consultant Microbiologist for the Newcastle upon Tyne Hospital's NHS Foundation Trust. And once again, same applies as earlier. If you've got any questions for our two guests, make sure that you take advantage of our live Q&A function, which I'm just going to click on mine, so that we can I can keep an eye on that on the right. Put any questions you have to the guests. Now, welcome to both of my panelists. It really is quite nice at an event like this. We often have 4 or 5 people on the panel, and we've just got the 2 of you. So I feel that we have the luxury, if you like, of being able to breathe a little bit more and finding out a little bit about who you are and your backgrounds. Julie, you're Head of Department and Consultant Microbiologist in Infection Control for Newcastle upon Tyne Hospital's NHS Foundation's Trust. So tell us a bit about you and your work and what that role involves.
Thanks, Helen. Yes, you're absolutely right. I'm a consultant microbiologist, and I've been the head of department for a couple of years now. It was quite a new role for me, but and I dived straight into it, and lo and behold, we got the pandemic. It was a very, very steep learning curve for me. My role really, I'm also the infection control lead for the site and the deputy director of infection control. So there are kind of, I wouldn't say they're competing roles, they kind of blend quite well together. And that was quite evident in the pandemic, because we had to do, the diagnostic side of the pandemic was equally important to manage the infection prevention and control aspects of the pandemic. So we complemented the role very well, and my role, there's also the clinical side of it, because we are a specialist hospital, a number of specialist areas of interest, and so we have consultants who are kind of manage various different clinical specialties as well. So it's a lot of different roles packed into one. So one package.
A lot of different roles packed into one. I mean, Tony, you're at the Royal Liverpool University Hospital as Consultant Clinical Scientist for Medical Physics and Clinical Engineering. Gosh, with a title like that, I take my hat off to you as a girl from Grimsby. Can you explain your expertise in the IPC, COVID-19 world, if you like?
Yeah, well, first of all, please don't confuse the number of words in my title with my competence. That would be a terrible mistake to make, wouldn't it? Okay. Well, I've got two roles, really. As an academic, I'm a professor of physics at the University of Liverpool. And in my NHS role, I'm a consultant clinical engineer and medical physicist. And I run a department of medical physics and clinical engineering at the Royal, as you said. Since the pandemic hit, because my original background was in medicine, I've been seconded to various C-19 response programs, initially at London Nightingale, then the Manchester Nightingale, where I helped run the near-patient biochemistry analyses. But for the last 6 to 9 months, I've been seconded to the Chief Scientific Officer's office to consult on aspects of clinical engineering, but particularly applied engineering directed towards ventilation of spaces and smart decontamination sanitization methods, principally using air scrubbing and ultraviolet light. A focus of my work has been putting the engineering behind the C-19 response program for mobile testing laboratories, where we initially mounted PCR, but now we've mounted LAMP. And we've got something like 50-odd mobile units about to circulate through the four countries. And the challenges, you might imagine, are extreme, when you've got colleagues working in very small areas with biohazards for long protracted shifts. So human factors are very important, and the controls that we might want to put in place in an ideal world just don't work when we're on essentially a war footing. And some of these people really are doing fantastic work, but under very, very difficult conditions. If you're in a van on the side of a motorway car park or something like that, and it's 28 Celsius outside or -12, there's some challenges that you have to meet.
We're going to dig a bit deeper in a minute, Tony, into ventilation and air scrubbers and that kind of side of your work. Julie, what a time to take a job like you took. I mean, the timing is incredible. What have the last 18 months really been like for you, and what's kept you awake at night?
I mean, it all started off with a request from our chief operating officer to say, oh, can we do 100 COVID tests? And it didn't, that itself was a daunting experience, having never introduced PCR in a diagnostic lab for COVID. We run the PHE molecular service, and we are the molecular service for the region. So it was a huge shock. And that meant pulling lots of key stakeholders. What are the priorities? What is the critical need? How do we maintain the staff? How do we reconfigure a space which is not meant to do something like this? So starting with that conversation, now we are sort of running over 1,000 samples a day for COVID. And we are also, Newcastle Labs are also hosting the Baltic Innovation Laboratory, which can run over 40,000 samples a day. So it has been an incredible journey, I want to say. Though it was challenging at times, it is always the thing that kept me awake was, how do I keep my staff morale going? Because it's okay to say that from April 20 to summer 20, that's it, COVID's gone away. But summer 20, it didn't go away. The summer 21, it's not going away. So the staff under pressure to work, because we've always maintained a lean workforce. So then try and do all of this with, we had a few transient staff, but the ones that are permanent are constantly feeling the pressure. So that's what kept me awake, that how do I keep my staff going day on and, for the next few years to come.
And the natural follow-on to that, Julie, is how did you keep morale up?
You know that biscuits and cakes are not going to cut it. So I think one of the fundamental things of keeping the staff morale up was trying to give them a monthly update. Initially, it was all weekly, because we call them weekly huddles, to try and tell staff where we are at in the pandemic and the role they play in the pandemic and how everybody's role is significant. So just keeping them involved in everything, whether it be a stressful situation or a happy situation. The main objective was that we are all in it together and we have to find a solution to this. So, the role that the biomedical scientists play in this whole situation was enormous. And we've got 100 staff within the Pillar 1 laboratory. And all of these 100 staff were put together all the time. So we had these communications with the chief operating officer, with our directorate manager, and key individuals from IPC and the diagnostic side, constantly reassuring people. But as you can imagine, it's not easy at all.
No, I'm sure you did a very good job of it. I can tell just from your personality that I'm sure you put a lot of thought and determination to make that work for everybody, because people weren't only dealing with their sort of working lives, they were also dealing with difficulties in their home lives too. Tony, I have to admit to you that I'm not any expert on ventilation, and ventilation has been a word that has been used a number of times this morning already. But what are the challenges of meeting the recommended ventilation standards in care settings? I would imagine it's not easy.
No, it's not. No. I've had the privilege of working with some very, very smart ventilation engineers over the last year, and they're pretty clear on what they think is necessary, how to enshrine standards which tell us what is necessary, and actually provide mechanical methods of delivering on that. However, what we've got is hospitals that were built years ago, have windows that don't necessarily open, and absolutely get nowhere near the ventilation, the minimum ventilation requirements that the new standards are specifying for new buildings. So from a sort of, I don't know, statutory point of view, having a hospital environment which falls very short of current standards is not illegal, if you like. You're not statutorily exposed, but as scientists, we can't unknow what we know. So if we look at, say, an endoscopy suite theatre in a late Victorian hospital where the ventilation is extremely poor, maybe there's none, we are faced professionally with a dilemma of, do we just say you mustn't go forward with clinical procedures because you fall so short of current standards, or do you say, well, you can go ahead because you're not breaking the law? So that's really quite a dilemma. So to try and resolve this dilemma without really affecting too much patient flows and staff safety, we've been looking at mitigations of poor ventilation. And you mentioned the word previously, air scrubbing, and that's been a big piece of our work, developing plug-in technologies that can lift the effective ventilation in non-optimally designed spaces.
And what are your thoughts? And maybe just tell us what air scrubbers are and what your thoughts are. I mean, I've seen that, a lot of claims that UV air scrubbers can clean or clear infected environments. Some of those comments have been quite extreme, and I just wondered what your thoughts are on those, and are air scrubbers sort of part of the solution, if you like?
Yeah. Well, there are a lot of snake oil salesmen out there at the moment, and they are flooding the market with what we call air scrubbers. Now, I'll say what they are in a moment. But this kit arrives in, say, dental surgeries. It arrives in certain theatres and outpatient areas in hospitals, and it kind of looks really good. It comes from Asia, and it's got a CE mark on it. And why wouldn't you want to use it? Because you read what it says on the label, and it's the answer to all your problems. But you have a very careful look at the CE mark, and it's not the CE mark that we endorse from MHRA. It actually stands for China Export, which has got no veracity at all in this country. So many colleagues working in dental practices where they're desperate to improve their environments, to get their patient flow working, have bought these devices, and we've looked at some of them. They don't work. They look great. They don't work. So there's a real pressure on now to put some standards together and really try and identify good technology in UK PLC and make recommendations to the NHS. So what is an air scrubber? Well, an air scrubber is a local device which simply takes in local environmental air, sanitizes it, and reintroduces it into the room. So it's like a fan heater, if you like, but instead of a heating element, it's got a well-designed, in a good piece of kit, a well-designed ultraviolet source. So the air emitting from this recirculation device goes through a powerful ultraviolet field, and that has got powerful bactericidal properties and powerful viral deactivation properties. And one can put these items as an add-in post hoc into clinical environments and effectively contribute air changes per hour figures. And we want, in a well-designed hospital, shall I say, an endoscopy suite, 10 changes of room air per hour. That'd be a minimum, I think, and that's what the new recommendation is going to be. If you put in one of these air scrubbing devices, you might get between 5 and 10 simply by plugging into the wall. Okay, so it's very kind of, on the surface, very, very easy to use, acceptable technology. When it comes to their real application and trying to bio-validate their performance, it's difficult and not impossible, because we don't enjoy a good understanding of bioburden at the moment. So what we've tried to do is part bioburden for somebody else and work very hard on the verification of the physics and the engineering to use that so overworked expression. Do these devices do what they say on the tin? So we'll be looking that if they claim to add 5 equivalent air changes per hour to a given space, do they have the airflow? If they do, is that airflow effectively sanitized? And we're working with a number of groups, expert groups around the country, to put some standards together. The bottom line is that there are a few devices made by UK manufacturers that do very much seem to tick the boxes. And we've started to roll these out in a number of scenarios, critical care wards, some outpatient waiting spaces, but most significantly in areas where aerosol generated procedures are a big issue. So they would classically be, yes, lower bowel and esophageal endoscopy and dental surgery. And dental surgery in theatres and hospital, and dental surgeries in the high street. And we're early in the program. I think there's probably, and I make up a figure here, 1,000 or so of these devices distributed across the 4 countries, maybe a few more. And the early verification results are extremely good. Sorry?
I'm not ringing you, but while you answer that, I'll pick up with Julie. Thank you so much for your explanation on that. Julie, I just thought it was interesting. Amy Lewis has commented. She says, how refreshing that staff morale was the main, one of your main concerns. So nice little comment there from Amy. But just wondered, Julie, are there any innovative new working practices that you've seen introduced which have really helped improve IPC measures?
So, I'm going to come purely from the diagnostic side because the maximum innovation happened within diagnostics, because that was fundamental for us to help our infection prevention control pathways. So, because we had the PCR testings on site, we could start the patient testing, the staff testing, and all of that very quickly. There was no reliance on sending samples to external laboratories. So, at one point, we've almost introduced 10 different diagnostic assays for COVID testing. We also introduced the Lumira, which was part of the rapid diagnostic assay it's a point of care testing that was helping the ED pathway, because within emergency admissions, you've got hundreds of patients coming in, all piled up, and we have no way to put them, as Tony explained. Some of the older buildings do not have that many cubicles, and you can't really plan and put people into green or amber or red pathways without knowing their COVID status. So getting the Lumira was quite a game changer for us, and that came up in December 20, and that's still on, and we've got almost 5 different kits across the trust. In addition to that, we also set up another facility at the RVI to do the rapid testing. So we had some rapid turnaround testing for COVID, which would give you a result within 3 hours. So we introduced a number of assays to help that. It was all about keeping the pathway clear and the flow, and we didn't want to cancel surgeries. So those were the kind of innovations that we brought in within the diagnostic sector. Within the sort of clinical side, I think it was all about, it's a newer way of looking at the patient journey, and there was not much of innovation from the IPC in terms of the clinical side, but we became very slicker, and as you learn with experience, you become more and more slicker, and you've almost rehearsed everything before. And so we could just apply a lot, because we formed a core group of people who would come together and bring all the problems to the table and take out the solutions and delegate and have key individuals in various parts of the organization to implement the change. Because I think the biggest issue that I've felt is the implementing and adapting change, which is where we always say you can do that through education, but it's not that easy unless you have a system that works. It's very difficult to implement the change.
And how did you achieve that? What were your tips for implementing change? What were the things you learned on that particular journey?
So I think one of the key there's some background. In the first few months, it was all about, we didn't know what the change was going to be, because there was always something that came up on a Friday afternoon. So within the IPC core team, we struggled to know what the next change was going to be. So that was one challenge. And then once you knew what the change was, we had to put that change out very quickly. So we started a sort of, I think most of the trusts would have started a NUT COVID bulletin that came out every day. So at a particular time in the day, there would be a core bulletin that went out with all the key changes. And the responsibility was with the directorate managers, the matron, and the clinical directors to pick up that bulletin and disseminate it to the team. So it's then out of habit. It's just about repetition. And then everybody knew that there is that time of the day you need to look at that bulletin because that would capture all the changes. Then we also had what we've called harm-free care leads identified within every clinical area. So it could be a ward, it could be a clinic, it could be a directorate. And they were then responsible for disseminating the change. And these could be any grades or any bands of staff. So it's just that sort of, board to board kind of approach that we kept applying and retesting the system to check has the change been implemented. We also had the white boards. So Newcastle hospitals went on to the electronic patient recording system a couple of years ago. And then we had the white boards installed where if you knew that patient had to be screened on day 3 and day 5, a trigger would come up. So the ward staff would know that this patient needs a screen. So those were the kind of changes, and it's a live, dynamic visual thing that's visible on the wards. So they know that that's something that has to be done and it's on the task list.
To somebody who isn't in the healthcare industry to get a little glimpse into what, went on in your worlds. I mean, we all know from the clapping we did for the NHS on a Thursday night, appreciative of people being on the front line, but it's fascinating to me to hear the innovation and the difficulties and challenges that you faced. Just looking at some questions, Tony, I think this would be perhaps for you. Christine would like to know, would you agree that ventilation was not rated as important until well into the second wave? And was this because there was a reticence to recognize the risk posed by infectious aerosols as being an important route of transmission?
Yeah. I mean, I follow the IPC angle from a slight distance initially, because we were just so full on looking at absolutely everything, hand touch, all those bits and pieces. But now all the stuff that we do for SAGE, well, 90% of the stuff we do for SAGE now directed towards the handling of the airborne component of cross contamination, which is cross infection and contamination of samples in laboratories, and the awareness of this is being led by Prof. Kath Noakes from Leeds, who sits directly on stage, and she's made some very, very good literature contributions recently on the airborne risk. I'd like to pop back, if I may, to the item I touched on previously, which was my example of airborne risk within endoscopy suites. Well, the way that many clinical directors have tried to mitigate these risks, first of all, needs to look at what we call, or I call, the surgeon's glove paradox. Okay, so if you imagine a surgeon, he or she wears this glove so that the contamination on their hand doesn't infect the patient during surgery. Okay, so that makes the glove, doesn't it, important in protecting the patient, so it's like a medical device. However, he or she also wears that glove so the contamination in the patient doesn't affect the surgeon and the other clinical colleagues. So that makes this an HSE perspective. So when we kind of do things in this environment, we have to have our HSE awareness and we have to have our MHRA awareness. And the engineering approach and the pragmatic approach of many medics is just to be very, very conservative. So in the endoscopy world, one might, for kind of routine biopsy, upper bowel stuff, be trying to process, unfriendly word, but colleagues will know what I mean, say 4 patients an hour, okay? But what we've had to do is come up with a figure of how long we leave the room empty in between patients. So if COVID has walked into the room, how long do we wait for the ventilation system to clear sufficient so the risk is manageable for the next patient and for the clinicians working in that clinical space? And clinical directors have just put their hand into the orchard and found a useful figure. So across the country, I've seen anything from 20 minutes to 2 hours. And who's to criticize these people? Because there's very, very little bio-validation work being done to actually say what is a sensible fallow time. But the longer the fallow time, the greater the impingement and disruption there is to clinical pathways. And it's very much affecting clinical delivery in these areas. And we know that waiting lists are really a very, very big issue. So directing smart ventilation and air handling to minimize the fallow time has proved extremely beneficial in improving the patient flow through these critical AGP exposed areas. And we put together some designs, very simple design tools that say, if you use this air scrubber piece of kit, you can reduce whatever fallow time you were using without it, you can reduce it by up to 80%, something like that, by some pretty basic scientific and engineering principles. And that seems quite successful. So in one particular hospital close to where I am at the moment, they were on 30 minutes fallow time. They put in one air scrubber, plugged it in the wall and asked me whether it's in the right place. And I said, I thought it was. They've gone down to 10 minutes. So that makes a dramatic improvement in the turnaround time for patients. So I would ask colleagues to look at this area and see whether it's appropriate to mitigating the risks that you have. And some of those risks, quite crudely, are failing to deliver effective clinical pathways in a time that manages patient flow.
A minute left. Julie, I'd like to ask you a question, and then I've got another quick couple of questions coming in from the audience for you, Tony. But Julie, first of all, very part of every NHS department, so there's always budget allocated. How do we encourage, Julie, senior leaders, organisations to invest in new innovations and to go above the current status quo?
Sorry, Helen, I missed the whole question. There's a lot of background noise.
Oh, I'm so sorry. I was just saying that, there is always budget allocated, isn't there, for infection prevention? But how do we encourage senior leaders and organisations to invest in new innovations and take us to the next level, go above that current status quo, if you like?
Yeah, I think with COVID, it was easy in a sense because we sort of had a pot and we knew it was a COVID pot and whatever needed to be done had to be done. It was almost like a free flow for us from the senior management teams and the executives because it was the pressure of getting done in a very time sensitive manner. So budget became, first time I think having worked in the NHS for all these years, I saw that budget was not a priority at all. And that made it very easy. So we could have as many, the IT structure was rechanged. There was lots of changes that were made. And that is proved a point. I think what we want to do is not forget the improvements that we've done when that structure is available. And it's always making that need real. That if you introduce these diagnostic facilities or you introduce all the kind of, we always prioritize within the budget, isn't it? What is it that's of maximum priority? Is the estates the priority? Is the IPC a priority? But they go hand in hand. And the things we do now, it's got long-term benefit. It's all about convincing the executive teams in the hospital that these needs, if we place them in the right order, the benefits will follow. It's not about the now that we're looking at. For COVID, it was all about now. But some of those changes will bring long-term benefits. But it's just the kind of removing all the kind of bottlenecks that we have within organizations, the contractual obligations, the managed service contracts, and all of that, and having a bit of a flexible approach within obviously, in a sort of guarded way, just proves that we can do a lot you can help a lot of people to try and achieve what they want if you don't put budget at the front of everything in a sensible way.
Tony, I'm going to put you on the spot now. We actually are out of time, but there's about 5 questions that it would be just really nice if you were able to give brief answers, if that's okay. And then presumably these people asking them can follow up with you on the platform. Teresa's asking, how do you measure the improvement in air quality once you've installed the air scrubber?
Okay, great question. That would be biovalidation, and we can't do it. So we use verification, and we use quite intensive computational fluid dynamics to look at the air dynamics throughout the room. And I've got some videos on this I can share with colleagues, and I invite anybody who's interested in following up on my modest contribution today. They're very welcome to email me with something appropriate in the subject line, so I recognize you as friends, not foe.
Okay, Donna says, are there plans to establish effective fallow time? What evidence do we have for best, and does it depend on end procedure being carried out?
Yes, it does, and the standards that we recommend will be purely based on CFD modeling on the basis of clearance, and it'll be up to local interpretation to find out to establish what clearance they are comfortable with. We've got a clinical paper coming out very soon where we sampled the air in 4 critical care areas in hospitals in the east of England, and we looked how red these areas were with and without air scrubbing, and the early results are really quite dramatic. It will not be a peer-reviewed paper because of rapid publication, but the early indications are those indications, which means we need to do more work urgently. But on the basis of early work, both hospitals have invested very, very heavily in the technology.
And Amanda finally says, where can one find guidance on ventilation? Oh, that's moved. Where can one find guidance on ventilation and use of air scrubbers in dental practice?
Right, email me and I'll start a conversation with you. The economics of this is absolutely great. In dental practices, the amount of fallow time reduction you can get, increased patient flow, pays for the air scrubber in 1 morning. So how about that for an economic argument for going forward?
And what a good way to end talking about innovation on. You've been fantastic guests. Thank you so much. It sounds like, Tony, you need a bit of a sort of a Q&A session with lots of people who are firing questions, and particularly on the technology side. But Julie, your contribution has been greatly appreciated too. It's actually been really nice for me just to have 2 guests and feel that we've been able to get a bit deeper into the subject. So thank you to you both. That was absolutely great. And I think there was some really interesting innovations there that, well, I certainly hadn't considered or knew much about. Right now, we're going to have a pre-recorded talk from Dr. Ben Kanter, Chief Medical Information Officer at Vocera Communications, discussing a number of the ways that effective communication devices which don't require the removal of PPE can support staff in working effectively and managing PPE stock. He'll also discuss gaps in caregiver safety and communications, as well as how technology can be used to help close these. I don't want to give too much away and steal the show, so here's Dr. Kanter to tell you more.
Thank you for spending time with me today. We only have a short time together, so I'm going to dive right in. I'll focus on some specific areas of clinical practice that have been profoundly impacted by the ongoing pandemic. These problems have been universal in their impact, affecting hospitals, patients, physicians, nurses, and other care team members worldwide. I'm starting with a photo that I think unfortunately sums up in so many ways so much of what has happened over the past year. So much that we had hoped wouldn't continue into this year and might continue to some degree into the next. And we see a frontline caregiver, completely isolated from any support, forced to communicate by holding a sign up or by writing on the glass window of the room. A sad situation for the nurse and a dangerous one for the patient. If you can't read the sign the nurse is holding up, it says, "Just going to hold his hand for a bit. I don't think he has long." By way of some personal background, I'm a pulmonary critical care physician who spent 28 years on the front lines. Unless you think the issues related to COVID are no longer immediately relevant to me, my wife is an infection preventionist, and my daughter is a nurse manager at a major academic medical center where she's been tasked with setting up and/or managing COVID testing sites, vaccination centers, and an ED surge tent. This photo is of the first testing center my daughter managed early in the pandemic. She's buried somewhere in the midst of that crowd, but we'll see more of her later. I can't really start to talk about the technological solutions we're using to combat problems exposed by the pandemic until you understand exactly what it is we do. So I'm going to take a few minutes and give you an overview of the Vocera Communication and Collaboration Suite, what it is, and a little bit how we accomplish it. And then I'll talk about specific applications that have proven to be very successful when caring for patients with COVID. To start with, we're an international company focusing on improving healthcare communications and collaboration across the care continuum. Our technologies are in use at more than 1,900 hospitals and healthcare facilities worldwide, including the countries of the Gulf Cooperation Council, the UK, Ireland, New Zealand, Australia, Canada, and the US. We were founded in 2000 and have just under 700 employees scattered around the globe, almost 10% of which have a clinical background. And I mention this because even though we're a technology company whose primary focus is on communication solutions, we know that the products we create are, in fact, clinical tools used by clinicians in the care of their patients. We invest a great deal of money into R&D efforts, and relevant to today's discussion is an award we received last November when Tyne magazine included one of our new devices, the Vocera Smart Badge, about which I'll say more in a bit, on their list of the 100 best inventions of 2020, specifically because of its utility in helping staff care for patients with COVID. Vocera provides a comprehensive communication and collaboration platform, aka CCNC, unifying calls, texts, and alarms on a single platform. By doing so, we make voice and text communication easier, help manage the confusing chaos of alarm management, all while shortening the time it takes hospitals to respond to areas of operational and clinical friction. We shorten the time it takes to act. Modern healthcare technology systems, whether clinical or operational, have an increased capability which allows them to communicate directly with frontline team members. Although this is done with safety and efficiency in mind, the reality is that these systems generally don't talk to each other. They each exist in their own silo. The end result is a situation where the unfortunate nurse can get barraged with uncoordinated interruptions. What's needed is a communication platform that can receive data from multiple different systems simultaneously and arbitrate the work, determine the relative priorities, and then distribute the work to the right person or teams. The analogy to air traffic controllers is one that's commonly used. You need a system that can make sense out of chaos and ensure that the right information flows to the right people using the right method at the right time. So how is this accomplished? Let's examine how Vocera's CCNC platform fulfills this need, and then we'll directly address issues related to COVID. At a high level, a CCNC platform is made up of three elements: inputs, a processing layer, and outputs. Vocera CCNC Suite provides a unified solution for hands-free voice calling, secure texting, alarm processing and routing, along with the expected audit and reporting tools. On the left, various hospital systems as well as staff members provide inputs to the system. Just to give you some perspective, our platform already has adapters or interfaces for approximately 150 different hospital systems. All of this serves as input to the main platform's intelligence, which is where the important actions take place. The goal isn't simply to connect information to people that's not particularly intelligent and wouldn't reduce the disruptions experienced by nurses. We need to do more than simply route data to staff. We need to orchestrate the work if we're to ease the caregiver's day while shortening response times. Now, there's a lot going on in the middle. The platform aggregates data streaming in from the various systems. That data can be integrated, so the data that ordinarily exists in silos can be merged and processed together, and then by using rules converted into information which itself may or may not require action. And that's an important point. Just because information exists doesn't mean it should be communicated. An intelligent CCNC system understands that knowing when not to send a message, knowing when not to interrupt, is just as important as knowing when messages should be sent. As but one example, when a nurse is participating in a medical emergency event, we strive not to interrupt him or her and instead direct communications traffic to whomever is available and backing her up. When a rule declares that information needs to be transmitted, the system acts by routing it to the right person or team based upon role, responsibility, and availability. The same platform constructs the audit trail and provides analytics and reporting services. In addition, given data feeds from care team assignment systems, integrations with the electronic health record, and scheduling systems, we're able to construct a dynamic care team, tracking who's currently working, what roles they've got, which patients they're caring for, and their presence status. Are they currently available or not? Understanding presence is critical. Construction of this real-time care team is crucial to our ability to deliver the right information to the right people and to reducing interruption fatigue. Finally, on the right side are the outputs. Modern communication platforms can message one or more people one or more ways with manual and automated escalations built in. If a nurse is unable or unwilling to respond, messages are automatically rerouted until delivery takes place. Importantly, a CC&C suite should be agnostic as to the mix of devices your staff needs to accomplish their job. Each role in the hospital has uniquely associated workflows, so each role will have a communication device, which best enables them to communicate, and if you will, a best communication tool for the job. Neither your electronic health record nor the communications platform should constrain your choices as to which devices are used by your staff. Many users are now equipped with smartphones. And while this has historically been the provenance of physicians, it's increasingly commonplace for nurses as well, particularly using enterprise provision devices. Vocera's Vina application runs on both iOS and Android platforms, giving the user complete access to all the functionality of our platform. The solution was developed in partnership with our user community, truly an experience that was designed by clinicians for clinicians. Vina includes an enterprise-wide directory and unique features such as a messaging inbox that sorts and presents messages and alarms, not just by time of arrival, but also by priority. In addition to our smartphone app, Vocera has been making hands-free communication equipment for approximately 20 years. The B3000N device on the left is now in its 4th generation. Although its primary users are generally nurses, they're also used by hospital-based physicians. It's small, lightweight, and worn either on a lanyard or clipped to a shirt or jacket. The device on the right is the newer Vocera Smart Badge. That's the device I mentioned earlier, which was recognized by Tyne magazine in November. This has a larger touchscreen, making it a better fit for a text messaging intensive environment. It has all of the functionality of the B3000, as well as an ability to be awakened using a smart phrase, such as, "Okay, Vocera," after which it will wake up and respond to voice commands. Both devices were designed specifically for use in healthcare and are easier, more efficient, and more economical to use than smartphones. So this takes us to the first COVID use case. Because the badges can be worn and used hands-free underneath PPE, they become critical technology for patient care in isolation environments and preparing for COVID patients. One thing we know for certain, the more things change, the more they stay the same. Now, this picture is taken from a woodcut titled "The Plague Doctor of Marseille." Although the engraving dates to 1721, the picture illustrates PPE worn by physicians starting in the early 1600s. What's remarkable about this costume is that although the concept of the germ theory of disease wouldn't be established for more than another 200 years, the precautions worn included a gown, glove, mask, and goggles. And here's my daughter, modeling for you typical modern barrier PPE consisting of a gown, glove, mask, and eye face protection. It's striking how little change there's actually been over the past 400 years. When you read studies focusing on the effectiveness of PPE, there's one glaring message that stands out to me. No matter how well trained your staff or well-intentioned the PPE design, the technology is not perfect. Self-contamination is unfortunately common when removing PPE. There are real and very meaningful usabilities with modern PPE. And because of that, a best practice is to minimize the number of times your staff has to doff PPE once it's been put on. And that includes for communicating with each other. Staff shouldn't be isolated from each other technologically when they're caring for patients in isolation rooms and wards. The practice of medicine takes a team, and a team can't function when members can't communicate. Consider other first responders, other frontline staff. Do police or firefighters go into action without radios to keep their teams in communication or to communicate if their own safety is threatened? Of course not. Yet that's exactly what we expect from our physicians and nurses. If you're in PPE and in a patient's room, if you need to communicate with your team or if someone needs to speak with you, you have to stop caring for that patient. Remove your PPE, wash your hands, and then you can pick up a phone or call for assistance for an x-ray, for a lab draw, or to conference with other physicians and nurses. Requiring staff to remove PPE in order to stay connected increases PPE waste, chews up valuable time, and exposes the clinician to a risk of self-contamination. Your staff shouldn't have to risk communication in order to have communication. So don't abandon your staff. Make sure they're safe and have a secure way to maintain communications with the rest of their team. We need to rethink the concept of what constitutes modern healthcare PPE. The ability to communicate is fundamental to providing care, and our devices enable this no matter the situation or isolation environment. The next use case leverages our ability to create and maintain communications with teams. Connect quickly with team members who have COVID-specific roles or members of COVID-19 management teams. One of the problems confronting workers in novel environments is knowing how to easily contact members of their team as they go on and off shift. Who's in what role, who's available, and who's not. Particularly when off-site in a remote vaccination center, how do you easily reach support staff who may be back on campus? Well, with Vocera, there's no need to worry about remembering names, numbers, or who's on call. You can connect with the right person or group using simple voice commands. You call by name or by role. Another frequent use case is to ensure clinical information is communicated to the appropriate team members as soon as possible. Time is precious. By integrating your electronic health record and other systems with the Vocera platform, the right care team members can receive push notifications with contextual information about physiological monitoring alarms, new orders, critical lab results, high-risk admissions, sepsis alerts, pain assessment reminders, patient consult requests, and much more. And the last use case I'll mention today addresses improving throughput. Management of a patient surge requires effective communication. With Vocera, you can configure the platform so that a bed cleaning request is automatically sent to housekeeping as soon as staff enter patient discharge or transfer orders into the EHR. The housekeeping team receives the bed cleaning request on their badge or smartphone and is prompted to verbally respond when the cleaning is in progress and completed. So in conclusion, we've accumulated 33 different ways to use our technology to improve the care for COVID patients and have compiled that information into a library document. If you use your favorite search engine and enter Vocera COVID or Vocera COVID Library, you'll be directed towards a number of practical resources. And remember, in order to provide optimal care for COVID patients means you need to provide your staff with optimal tools. And as I hope I've convinced you, communications technology should be considered an integral part of modern PPE, a crucial tool for caring for patients in isolation. Thank you very much.
Fascinating stuff there from Dr. Ben Kanter, and it just shows, doesn't it, how important even some of the simplest things are. I was quite taken by that picture he showed of 400 years ago, and then his daughter wearing all the PPE gear and talking about how important it is to communicate in these terrible times. We're all going to move now. We're going for our third leaders debate. So if you want to move on your timeline and join me in a second, that'd be great.